Yeah, hello guys. So, good evening, all of you. Welcome you all for this second year class. In this, we are going to discuss important MCQs of autonomic nervous system. Especially for second year, this class has been designed. We are taking these classes every month, one topic. We have taken general pharmacology in the last month. This month, we are going to cover the ANS. So, in this class, we are going to discuss 25 MCQs of ANS, covering most of the important topic in the autonomic nervous system. So, let's start with this question number 1. So, if you see the question, a person presented to emergency in comatose state after consuming some unknown poison. So this question is related to poisoning. As you know, in ANS poisoning, lot of questions are there regarding the poisoning. Excessive sweating is apparent, and on examination there is bradycardia and BP is 80/60. It means low BP. So there is, you can see the BP is low, the heart rate is low. So low BP, low heart rate, right? You can also send your message via chat if you have any doubt. The chat box is also open. Okay, I can see your chat. So, which of the following is the best antidote for treatment of this patient? So, if you see the patient present in emergency with comatose state, consuming some unknown poison, sweating is apparent. Whenever you see sweating, sweating means cholinergic receptor. Sweating means cholinergic receptor. So it means acetylcholine level is high or cholinergic actions are high. Muscarinic receptor is there. M3 receptor is present on the sweat glands. On examination, there is bradycardia and low BP. So low BP and bradycardia, that means again it is the acetylcholine. So it's a cholinergic action. It's a cholinergic poisoning. So which cholinergic poisoning? In cholinergic poisoning, the common poisoning is organophosphate or carbamates poisoning. Organophosphate or carbamates poisoning. Commonly seen in the farmers, because farmers are using the pesticides, or it can be due to some insecticides. The organophosphate poisoning is very common. So what is the best antidote for treatment of this poisoning? So the best antidote, neostigmine is a cholinergic drug, so definitely no. Atropine is anticholinergic, so it could be yes. Physostigmine is cholinergic. And acetylcysteine, that is the antidote for paracetamol poisoning. So what is the correct answer? It is the atropine, which is the correct answer. So atropine is the drug of choice. Atropine is the drug of choice to treat cholinergic drug poisoning. These symptoms can also be seen in the early mushroom poisoning, which is called as muscarine type of poisoning. So in muscarine alkaloid also you will see the same poisoning. Now let's see the next question. In the next question, if you see, just a minute. Yes, तो ये इंटरफेयर कर रहा है, तो we can put it over here. Okay, now let's see the next question. Next question is about the modafinil. Modafinil used as an adjunct in the treatment of all of the below conditions except. So first we need to know what is modafinil. Modafinil is one of the CNS stimulant. It is one of the CNS stimulant. It is definitely less abusive substance than the amphetamines. It's a good CNS stimulant. Where it is approved? It is approved for narcolepsy. It is approved for narcolepsy. Narco means sleep, lepsy means attack. So these are uncontrollable sleep attack. It is approved for narcolepsy, right? It is approved in narcolepsy for sleep attacks. Then the second important is it is approved, but there are some conditions where you can use the compound for off-label purpose. It means the drug is available in the market, off-labelly you can use it. So like in the shift work disorder. Shift work disorder, that means suppose a patient who is having shift duties from day to night, then night to day. So sleep pattern will be changed, and because of that you will see the person who has habit of sleeping in the daytime because of the night shift duties. Now if you put the patient on the day shift, the patient is the having the sleepiness. So in these type of patients also we can prescribe. Then the shift worker also you can prescribe for CNS stimulant purpose. If you want to keep the person alert, you can give this drug. Commonly used in the shift workers. Also in the OSA patient, it is not the treatment of choice, it is not the treatment for obstructive sleep apnea, but in sleep apnea patient, to increase the alertness, to decrease these naps, we can use this drug. So that is also useful. But what about the insomnia? Insomnia, already the person is alert, so definitely we never use CNS stimulant for this purpose. Any other drug which is CNS stimulant, that is caffeine. Caffeine is also CNS stimulant drug. Caffeine, we have the caffeine tablets. Also we have the amphetamines, but caffeine is available. And modafinil is the drug of choice for narcolepsy. It is the drug of choice for narcolepsy. Any other drug for narcolepsy? Yes, for narcolepsy we have two more drug for narcolepsy. What are these? Anybody want to reply? What are the drugs for narcolepsy? What are the drugs for narcolepsy? Any bacha? So other than this modafinil, modafinil is the drug of choice. We have tiprolicent. So tiprolicent, which is also called as pitolisant, it is the same drug. Tiprolicent or pitolisant is the same drug. This is basically H3 receptor inverse agonist. It is acting on H3 receptor. So H3 inverse agonist. H3 inverse agonist also approved for narcolepsy. And other than pitolisant, one more drug is there, that is solriamfetol. This solriamfetol is NDRI. What is NDRI? Norepinephrine dopamine reuptake inhibitor. So we have the total 3 drug. Remember modafinil, then pitolisant or tiprolicent, and solriamfetol. Remember the 3 drug MTS. Modafinil, tiprolicent, and solriamfetol. These are the drugs which are approved for narcolepsy, right? But insomnia is just opposite condition, just opposite. So this is about the second question. Now let's discuss the third question. A child present with history of ingestion of some unknown plant develop mydriasis, tachycardia, dry mouth, warm skin, delirium. DDD. Tachycardia means dhak dhak, dilated pupil, dry mouth, dry warm skin, delirium, confusion like state. Which following group of drug is likely to be responsible for the symptom of this child? So what do you think? Which type of symptoms are these? Dry mucosa, dry skin, dilated pupil, dhak dhak, decreased urination, decreased defecation, and delirium. All these symptoms, D. All these symptoms are related to belladonna. All these symptoms are related to belladonna, or you can say the dhatura poisoning. So in belladonna or dhatura poisoning, you will see these type of symptom. Any बच्चा बताना चाहते हो which group of drug is belladonna? Is it anticholinergic? Is it sympathomimetic, cholinergic or sympatholytic? What do you think? कौन से ग्रुप का ड्रग है बच्चे? Anticholinergic, sympathomimetic, cholinergic or sympatholytic? Where you will find these type of symptoms? Where is delirium, confusion like state, मतलब थोड़ा memory चला गया है, some memory loss, that is causing confusion. Then we have the dilated pupil, dry hot skin, so high grade fever, there will be dry mouth, difficulty in swallowing, there will be decreased urination, decreased defecation because peristalsis slow, bladder contraction slow. Also you will see that the patient is having tachycardia, dhak dhak, palpitation. So all these symptoms when you block which receptor, all these symptoms where you block, yes, very good बच्चे, बहुत बढ़िया, right? So we have this symptom because of Datura poisoning. Datura is anticholinergic atropine. Datura is anticholinergic atropine. That is the atropine. Can any bacha tell me what is the treatment for this Datura poisoning? What is the treatment for this Datura poisoning? What treatment you will give to these patients? The treatment for Datura poisoning is one of the cholinergic drug. Which cholinergic drug is best to treat Datura poisoning? Which is the best drug for treating the Datura poisoning? If I give you the two choice, is it physostigmine or neostigmine? Which is the best choice for Datura poisoning? Because both these drugs are cholinergic drug, but what is best? The best is physostigmine. Why not neostigmine? Because neostigmine is not reaching to brain, and you know, in this patient there is delirium, so we need the drug which can reach to brain. So physostigmine is lipid soluble and neostigmine is water soluble. So because of this, physostigmine is the drug of choice for Datura or atropine overdose. Okay, चलिए बहुत बढ़िया. Let's see the next question. All these are clinical important question. So let's see the next question. A patient was given IV penicillin, suddenly developed rash on the skin, swelling of the lips and eyelid, BP low, hypotension and difficulty in breathing. What do you think? After penicillin injection, penicillin is one of the drug which is having the risk of allergy, hypersensitivity. So this patient developed rash, swelling of the lips and eyelid, difficulty in swallowing, difficulty in breathing, hypotension. So there is bronchoconstriction, there is laryngeal edema, there is low BP. So all these because of the increased histamine in the allergy. From the mast cell, histamine release, and this histamine will cause these allergic symptoms. And this is a typical case of anaphylactic shock. This is a typical case of anaphylactic shock. This is a typical case of anaphylactic shock. So, बच्चे, what is the drug of choice to treat above condition? What is the DOC? Drug of choice to treat above condition. What do you think? 1 is 2000 adrenaline, 1 is 2000 adrenaline via IV, or 1 is to 10,000 via IV, or 1 is to 10,000 intramuscular. What do you think? So in this case, because there is increased histamine, what is the treatment? We have the three important drug for anaphylactic shock. One, we use the physiological antidote for histamine. What is the physiological antidote for histamine? Very good, Soni ji. Very good, bache. So the first important is physiological antidote, and that is the adrenaline, because histamine causing vasodilation, histamine causing bronchoconstriction. What is the role of adrenaline? This adrenaline will cause bronchodilation and increase BP. So adrenaline can physiologically reverse the histamine action. So that's why it is the best antidote for anaphylactic shock. Also, we can use the H1 antihistaminics. You can give the drug which block the histamine receptors. So we have the chlorpheniramine, promethazine like drugs, antihistaminics we'll discuss in the autocoids. And definitely there is corticosteroids. Allergy, to allergy we need the steroids as well. Steroids are good anti-allergic drug. So these three drugs are used, but out of these the life-saving drug for each patient is adrenaline. That is the drug of choice. In these patients, the dose of ADR is also important. So you use the 0.5 milligram, 1 is to 1000 solution via intramuscular in the thigh. So 1 is to 1000 solution of adrenaline used intramuscular. Yes, we definitely use the steroid. Hydrocort is the best option because hydrocortisone is the fastest acting, short acting corticosteroid. So we use the antihistaminic, we use the hydrocort in the emergency, but the life-saving drug to reverse these action of histamine is adrenaline. So the best answer will be option A. 1 is to 1000 of ADR intramuscularly in the thighs. That is the best option. The dose is 0.5 milligram. Don't forget it. Don't forget. Because IV is not the best option in the shock patient because it is difficult to access the vein. So intramuscular is the best option. Okay बच्चों, चलिए नेक्स्ट क्वेश्चन. तो ये सारे सेकेंड ईयर के हिसाब से इंपॉर्टेंट टॉपिक्स भी हैं और ये नीट पीजी में भी काम आएंगे, राइट, नॉट ओनली फॉर सेकंड ईयर, दीज आर इंपॉर्टेंट फॉर योर नीट पीजी एग्जाम, फॉर योर INICET एग्जाम, फॉर योर if you are preparing for FMGE exam. So all these medical exams, these are important, these topics. So young male giving history of excessive blinking of one eye since last 5 to 6 years. He is not able to control this, movement, and when he tried to control the frequency increase, very difficult situation. This is affecting his professional life, decrease his confidence level. What is the best drug for this patient? So what is the diagnosis? The important thing is always try to make a diagnosis. That's why we always said attend the clinics, attend the hospital, try to see the patients. You will find a lot of information. Medical science is vast. Whatever knowledge you get, that is less. Always try to get more and more knowledge. So young male, history of excessive blinking, and when he's trying to control the frequency increase, so definitely it will affect the professional life, his confidence as well. If you are not able to control on your thoughts, on your these movements, then definitely you will have the low confidence. So what is the diagnosis? The diagnosis in this patient is सोचिए क्या हो सकता है? So these are basically tic taurate. So this is a taurate syndrome. These are tics associated with the taurate. So in this you will see the abnormal movements, motor. So motor tics are there. Yes, very good, Soni ji. So these are motor tics. If they are causing the anxiety or low confidence, then definitely it is associated with the syndrome. So that is called as taurate syndrome. Movie था ना, हिचकी movie, उसमें यही था. Rani Mukherjee was diagnosed as taurate syndrome. So what is the first line management for tic taurate syndrome? What is the treatment for tic taurate syndrome? What is the first line drug for tic taurate syndrome? Yes, in these patients our aim is to control this anxiety first. Control this anxiety. Definitely this is a vicious cycle. To control the anxiety, also the drug which have some muscle relaxant property, so that can also control these motor movements. So the best drug is alpha 2 agonist, clonidine like drugs. So clonidine or guanfacine, these are alpha 2 agonist, and these are the first line drug in these tics nowadays. So clonidine or guanfacine. Then what are the other drugs we can use for this patient? Other than these, we can use the benazines, dopamine depleters. Dopamine depleters can be used like tetrabenazine, antipsychotics. All these drugs we are using in these Tourette syndrome patients. All these drugs we can use. Methylphenidate can be used for increasing the alertness. In these patients, atomoxetine, methylphenidate, they can be used, but they are not for controlling the tics. So what is the clone? The risperidone can be used, but that is not a first choice. Methylphenidate can be used in this patient, but not a first choice. The clonidine is the drug which is the first choice of drug in this patient. Don't forget that. So that is about the abnormal movement disorder. The clonidine is one of the alpha 2 agonist. Alpha 2 is presynaptic receptor which control the sympathetic activity. So you can say it's a central sympatholytic drug. These are central sympatholytics. They are central sympatholytic drugs, clonidine like drugs. So clonidine or guanfacine. Chaliye, let's see the next question. Preganglionic sympathetic and parasympathetic fibers. Preganglionic release DAS. Postganglionic parasympathetic fibers release DAS in the muscarinic receptor. Postganglionic sympathetic fibers release DAS in the sweat glands. So you have to fill these blanks. So what do you think is the first one? This is number 1. This is number 2. And this is number 3. So what is number 1? Preganglionic. At the ganglia, whether it is sympathetic ganglia or parasympathetic ganglia, what is the what is the receptor? NN receptor. NN. In the NN receptor, the neurotransmitter is acetylcholine. that the ganglionic or preganglionic region, it is the acetylcholine. Very good, bache. Then we have the second number. In second number, it is the postganglionic parasympathetic. In parasympathetic, it is the muscarinic receptor. And what is the neurotransmitter for these muscarinic receptor? It is again acetylcholine. The third number is postganglionic sympathetic fibers. And sympathetic fiber, what is the receptor? In the sweat glands. In the sweat glands, again we have the M3 receptor. Because the sweat glands, they have the sympathetic cholinergic activity. The M3 is again acetylcholine. So no confusion. It is acetylcholine, acetylcholine, acetylcholine in all these three columns. Very important question. Good. बहुत बढ़िया. Which of the following is a correct match for anti-glaucoma medications? Correct match for anti-glaucoma medication. So in anti-glaucoma, we have the two type of drug, the drug which decrease the secretions and the drugs which increase the outflow. We have these two options, the drug which decrease the secretions and the drug which increase the outflow. The drug which decrease the secretions are A, B and C. Alpha agonist, beta blocker and carbonic anhydrase inhibitors. Alpha agonist, beta blocker and carbonic anhydrase inhibitors. The drugs which increase the outflow, in this you will see the cholinergic drugs like pilocarpine, prostaglandins, PGF2 alpha like latanoprost, and we have the netarsudil, that is the Rho kinase inhibitor. These are the drugs. There are two groups. Out of these, prostaglandins are overall best option. So you can see timolol. Timolol is a beta blocker. Increase the aqueous production? No, it decrease the aqueous production. Netarsudil, it's a Rho kinase inhibitor. And it is increasing the trabecular outflow. Yes. Brimonidine is alpha 2 agonist, and these alpha 2 agonist, you can see they decrease the secretions. Latanoprost increase the trabecular? No. Latanoprost or prostaglandins, they increase the uveoscleral. Outflow. Rest of the two drugs increase the trabecular outflow. So now you can see out of these, what is the correct option? Only one is the correct option, and that is the netarsudil. And you know what is the important side effect of netarsudil? Netarsudil causing vortex keratopathy. That is the important side effect of netarsudil. So there is deposition over the cornea. The other Rho kinase inhibitors are like ripasudil, fasudil. They are used as vasodilators in the heart patients like angina, pulmonary hypertension. Okay, let's see the next question. Which of the following drug is used for the treatment of urge incontinence due to overactive bladder? Patient is having overactive bladder, there is urge incontinence. In the bladder, this is detrusor muscle. So overactivity, that means the bladder will contract. So our aim should be give the drug which relax the bladder. So we have the two options. One is beta 3 receptor, one is M3 receptor. To either stimulate the beta or inhibit the muscarinic. So sympathomimetic or anti-muscarinic. Out of the sympathomimetic, we have the drug mirabegron. So remember, bag relaxation on mirabegron. And in M3, the important drug we have like oxybutynine, solifenacin like drugs. Are there. We have many other drugs in anticholinergics, so you can say soft drugs. Solifenacin, oxybutynine, flavoxate, tolterodine, these type of drugs are there. But definitely not bethanechol, because bethanechol is a cholinergic drug. By name only you can see. And cholinergic drugs will cause the contractions. Definitely not duloxetine. Duloxetine is a drug which is antidepressant, which can be used in stress incontinence, not for... It is used for stress incontinence, not for urge incontinence. So that is basically having the effect on the sphincter. Due to stress, there is sphincter leakage. So in that case, we use the duloxetine. What is the correct answer? It's a mirabegron, wonderful drug for urge incontinence patient, overactive bladder patients. So nowadays, mirabegron is preferred. The important side effect of mirabegron is tachycardia. The important side effect is tachycardia, increased heart rate. Okay, because all these sympathomimetic drugs, they have the risk of tachycardia because they have some effect on the heart. Okay, let's see the next question. A 70-year-old man, Ramkumar, comes to you having irritative symptoms due to retention of urine. The patient is old, 70-year-old man, retention of urine, diagnosed to have the benign prostate hypertrophy, the BPH cases. The drug which provide the relief of symptom in this patient is, so if the patient is having BPH, there is irritative symptoms due to retention of urine. So what is our aim? Our aim is to relieve this retention, because if there will be no retention, there will be no irritative symptoms. Because of the obstruction, there is retention of urine, and this retention causing the irritation. So what drug you will use? Yes, bache. So the options are bethanechol, imipramine, tamsulosin, or dutasteride. What do you think? Which drug you will use? Always remember, in BPH, our target should be relieve the obstruction, increase the flow. If you will increase the flow, rate, automatically the retention will be relieved. And if the retention will be relieved, then there will be no problem. So yes, the first drug we start in this patient is, it's a tamsulosin. Tamsulosin is the alpha 1A blocker. It will increase the flow rate, and that will relieve the retention. So that will relieve the retention of urine. If after retention, relieving the retention, still the patient is having the irritative symptom, then we can use the anticholinergic drug. Dutasteride can be used in the BPH, but that is a drug to decrease the size of prostate. That is to decrease the size. That is a static component. Tamsulosin is acting on the flow rate. That is a dynamic component. Imipramine can be used for irritative symptoms, but that is because that is having anticholinergic effect. But that is only used if the patient is having no BPH. BPH is means the flow rate is already high. Then only we can add. Otherwise, we never use imipramine like drugs in the BPH patients. So the best option will be tamsulosin. One more drug is available in the market nowadays, and the name of the drug is silodosin. So this is osinosine. So tamsulosin, silodosin, these are the important drug for the BPH to relieve the retention of urine. Let's see the next question. A 68-year-old man, again the man is old, 68 year, present to emergency department with acute heart failure. Patient is having acute heart failure. You decide that the patient requires immediate drug therapy. Patient requires immediate drug therapy to improve his cardiac function. Which of the following drug would be the most beneficial? Yes, bache, very important question. Emergency, again you can see all these clinical questions. So which will be the most useful drug for this benefit of this patient? Options are albuterol. Albuterol is basically salbutamol. That is a beta 2 agonist. Dobutamine. Dobutamine is beta 1 agonist. Epinephrine, that is alpha and beta agonist. Norepinephrine, all alpha beta agonist except beta 2. Yes, so this is a case of acute heart failure. Patient heart is not having action. It means pumping action is not proper. So you can say this is a typical case of acute pump failure. Many times you will see patient comes in acute pump failure because of the MI. So patient is having MI, myocardial infarction, pump fail. What is the drug you will give to improve these cardiac functions? Very important, very commonly used in emergencies. Patient, heart condition, acute pump failure. The drug which increase the pumping action. Which drug you will use? See, if they are asking the patient is having congestive symptom, then the scenario will be different. But in this, the patient is not comes in congestive. The patient heart is not pumping. So we need to give the inotropic support. So in this case, we use the inotropes. You know what is the role of inotropes? Inotropes are the drugs which support the heart for pumping. They increase the contractility. So definitely we need the beta 1 receptor. Beta 1 receptor in the heart. So you need to support the beta 1 receptor. Now definitely not salbutamol. Definitely not the salbutamol. Now out of these three, which is best for this purpose? Not epinephrine. Why not epinephrine? Because epinephrine is having high risk of arrhythmia. Very sensitive. Myocardium is very sensitive for epinephrine. Epinephrine, just imagine epinephrine or this adrenaline. Very sensitive. There is a risk of arrhythmias. So not C. Never use epinephrine in acute pump failure. Epinephrine is good for cardiac arrest, not for acute pump failure. In this you can see there is acute heart fail. Heart is not pumping. So if heart is not pumping, then what is the drug to give the inotropic support? Epinephrine having risk of arrhythmia, sudden death is possible. So never use. So now you have the two options: dobutamine, norepinephrine. One option is also there, that is dopamine. So out of these, which is the best inotropic support for heart? That is dobutamine. You can say it is selective for beta 1. Very good support for heart, and it is the best drug for acute heart failure or acute pump failure. As inotrope, it is the best inotrope. Norepinephrine is good if you want to increase the BP. So if the patient is in shock and you want to give a drug to increase the BP, then it is norepinephrine. So norepinephrine is the best drug to increase the BP. It's a vasopressor agent. So for vasopressor purpose, norepinephrine. For acute inotrope, dobutamine. So dobutamine first choice. If not in the option, then we have the dopamine. If not in the option, we have the noradrenaline or adrenaline. All these can be used, but the best is dobutamine because of the minimum load over the heart, less risk of arrhythmia. Dobutamine is a best choice. Okay, chaliye, let's see the next question. One drug addict person present to the with ulceration over the skin. This patient also having itching and scratch marks over the skin. He is having tachycardia. He is having hypertension and mydriasis. Which substance is causing these symptoms? And there is skin ulceration, or you can say the scratch marks over the skin, tachycardia, high blood pressure, pupil dilate. What do you think? Which substance can cause these problems? So remember all these because of the sympathetic. Sympathetic is high. It means NORAD is high. Increase noradrenaline. And also there is skin ulcer. So what do you think? कौन सा substance हो सकता है बच्चों? Think and tell me. Is it heroin? Is it cannabis? Is it cocaine or LSD? So always remember, there is no role of cannabis in this patient, because cannabis do not cause tachycardia, high blood pressure. Cannabis cannot dilate the pupil, because cannabis do not increase the sympathetic activity, and there is no role of cannabis on the skin ulcer. That one is out. Now second, heroin. Heroin is out. Why? Because heroin is opioid, and opioids are decreasing the sympathetic activity. Opioids decrease the heart rate, decrease the respiratory rate. Whenever you see the heroin, you will see the heart rate is decreased, the respiratory rate is decreased, and the pupil is meiosis. Pupil is meiosis in the heroin opioids. So that is out. LSD can cause hallucination, but LSD do not cause the hallucination of tactile type of hallucination. LSD causing some visual hallucinations. So now it is the cocaine which can cause the tactile hallucination. So these are basically tactile hallucinations, or you can say the cocaine bugs. So because of these hallucination, patient is having the scratch marks over the skin. Sharp knife से scratch कर रहा है. Also cocaine increase the noradrenaline. It is the norepinephrine reuptake inhibitor. So because of norepinephrine reuptake inhibitor, NRI, it increase the norepinephrine. And because of increased norepinephrine, all these symptoms due to cocaine overdose. So these are the symptoms of cocaine overdose. To control these symptoms, give the sympatholytics clonidine. So if the patient comes with the cocaine overdose, give the clonidine like drugs. So that's why it is the cocaine. Next question, very simple question, direct question. Which antihypertensive is not safe in elderly patients because of risk of precipitation of asthma, bradycardia, and heart failure? So, which drug used as antihypertensive could be risky in these patients because of risk of asthma, because of risk of bradycardia, because of risk of heart failure? So, we have the options. Indapamide. Indapamide is one of the thiazide diuretic, and diuretics are not having any problem in asthmatic patient or heart failure or bradycardia patient. So diuretics are not unsafe. Amlodipine. Amlodipine is a calcium channel blocker. So it's a diuretic. It's a calcium channel blocker. Even calcium channel blockers are best in asthma because they are bronchodilator. Enalapril, that is the ACE enzyme inhibitor, and that is also not unsafe in these patients. So the drug which is unsafe for these patients is, that is, propranolol. So propranolol is a beta blocker. It's a non-selective beta blocker which is not good in old patient because it can precipitate the asthma attack. It can precipitate the bradycardia. It can precipitate the heart failure because directly inhibiting the heart, that means decrease the pumping action of the heart. In the severe heart failure, we never use propranolol. We can use the beta blocker only in mild moderate heart failure, just for inhibiting the compensatory mechanism, but never use in severe heart failure, acute heart failure patient. So these are the conditions. So that's why in these patients, propranolol is not a good option. So basically you can say these are the contraindication of beta blockers. Okay. So the next question is very simple question, clinical question. A patient 58-year-old had laryngeal cancer, undergone neck irradiation. After that, she has decreased salivation and dry mouth. Which of the which of the following drug is not useful? Which of the following drug is not useful in above condition? So which drug is not useful in above condition? Cevimeline, atropine, anticholinesterase or pilocarpine? बताओ बच्चों. Patient is having decreased salivation, so you can say this patient is suffering of xerostomia, dry mouth. So what is the drug for treatment of xerostomia? If you want to increase the salivation, which drug you will use? We use the cholinergic drugs because cholinergics can increase the secretion, so it is the M3 receptor. Options we have cevimeline, atropine, anticholinesterase, pilocarpine. So what do you think? Pilocarpine is M3 stimulator, cevimeline is M3 stimulator, anticholinesterase is indirectly acting cholinergic drug. But what is the atropine? Atropine is the muscarinic antagonist. Now tell me, which drug out of these is not useful in above condition? So in above condition, the drug which is not useful is atropine because atropine itself causing dry mouth. So atropine is not useful. What is the best drug in these cases? The best drug nowadays is cevimeline. The best drug is cevimeline. चलिए next question. An elderly patient was diagnosed with Alzheimer's. तो एक चीज नोटिस किया आपने, most of the patients are now today elderly patients. So Alzheimer's disease due to symptoms of dementia. Which drug is given to treat this patient? So what are the drugs for dementia? In dementia treatment, which neurotransmitter? It is the acetylcholine. The first group of drug we use is the central cholinergic drugs. We use the central cholinergic drugs. And what are the central cholinergic drugs? The important drug is donepezil, galantamine and rivastigmine. Donepezil, galantamine and rivastigmine. These are the drugs. These are the drugs. Donepezil, galantamine and rivastigmine. Out of these, rivastigmine is available in the patch form today. Nowadays, the patch form is available. So which drug out of these? Pyridostigmine is not reaching to brain. Neostigmine not reaching to brain. Rivastigmine reaching to brain. Edrophonium not reaching to brain. Out of these, only one is lipid soluble. that is rivastigmine. So remember, the patch form of rivastigmine is available in these tablets. Donepezil is good because that is longer, but overall patch is preferred nowadays. So rivastigmine patches are available for dementia patient. Nowadays we also have role of some other drugs. So one important drug we have is the memantine. Memantine is the drug which is NMDA blocker, NMDA glutamate receptor blocker. And we have the role of some monoclonal antibodies like lecanemab, donanemab. So these are monoclonal antibodies. NE, nervous system monoclonal antibodies. NEMAB. So NEMAB is for nervous system. Lecanemab, that is against amyloid deposition. So if inhibit the amyloidosis, inhibit the memory loss. चलिए, next question, a simplest question of today. Propranolol is not useful in which condition? In tremors, is it useful? Yes. Except one type of tremor we don't use, that is Parkinsonism. Except Parkinsonism. HOCM, hypertrophic obstructive cardiomyopathy. So the role of beta blocker is to inhibit the hypertrophy. So these are used as negative inotrope. So beta blockers having negative inotrope, so they are useful. Inhibit the hypertrophy because they inhibit the contractility to inhibit the hypertrophy. Angina. Can we use beta blockers in angina? Yes, because of negative chronotrope. Negative chronotrope means they decrease the heart rate. If they decrease the heart rate, they decrease the oxygen demand. So beta blockers are cardiac depressant, they decrease the oxygen demand. That's why they can be useful in chronic angina patients. Partial AV block. If already AV block, we never use this because already there is negative dromotrope. If you slow the conductions by using the beta blocker, there will be more slowing of conductions. So that's why AV nodal delay, they can be risky in these patients. So in which patient out of these beta blockers are not useful? If already suppressed heart, never use the beta blocker. Partial heart block, never use. Can you tell me what is the name of the drug for this heart block? What is the best drug for partial heart block? Any bacha? What is the best drug for heart block? So in the partial heart block, Mobitz 1 heart block, what is the best option? Okay, the name of the drug is from the anticholinergic group. अब बता दो, anticholinergic. So which is best? Anticholinergic used in heart block. So that is only and only one, atropine IV injection. So atropine is the best drug for heart block. Okay, चलिए, let's see the next question. All are the true about neostigmine except. So right now we have discussed कि sir neostigmine is the drug which is tertiary ammonium compound. So it is not ammonium, basically amine. Sorry, tertiary amine. So it is the tertiary amine compound. Yes, not quaternary ammonium. That is tertiary amine. So that is about the neostigmine. Okay. So neostigmine is one of the quaternary ammonium compound, not the tertiary amine. Reversal effect of depolarizing muscle relaxation. Depolarizing muscle relaxation. Which is the depolarizing muscle relaxation? It is succinylcholine. It is the succinylcholine. Succinylcholine. Used in cobra bite treatment. Cobra bite snake. Where is the neurotoxic snake? Muscle weakness. Reduce the post-op paralysis, post-op paralytic ileus. So yes, is it for post-op ileus? Yes, because it increases the peristalsis. Is it for cobra bite treatment? Yes, to increase the muscle activity. Is it for reversal effect of depolarizing muscle relaxation? No, it is for non-depolarizing muscle relaxation. Curare like drugs. Curare. So these are curare. These are curare like drugs. Tubocurarine. So for that it is used as reversal, not for succinylcholine, because succinylcholine itself having effect on acetylcholine like receptors. Now अब यहाँ पे थोड़ा सा कंफ्यूजन है, थोड़ा सा ये ऑप्शन गलत हो गया. तो इट इज बेसिकली नॉट टर्सरी, यहाँ पे लिखा होना चाहिए था क्वाटर्नरी अमोनियम. तो इट इज क्वाटर्नरी अमोनियम. तो अमोनियम, अमोनियम मीन्स आयोनाइज्ड कंपाउंड. यस, तो इट इज द आयोनाइज्ड कंपाउंड और यू कैन से द वाटर सोल्यूबल. तो क्वेश्चन बनाते समय थोड़ा सा मिस्टेक हो गया. So it is the quaternary ammonium compound. Yes, it is the quaternary ammonium compound. That's why it is not reaching to brain. So what is the correct answer? Option B is correct answer. It is not reversing the effect of succinylcholine. It is reversing the effect of curare-like drugs. Can you tell me some, one important reversal nowadays for rocuronium? Which reversal is available in the market for rocuronium? Specifically for steroidal rocuronium. Which reversal is available? Because neostigmine ka is cheaper, it's good, but rocuronium is more specific binder. So which is specific binder for rocuronium? काफी यूज होता है बट महंगा है, इट्स कॉस्टली. तब तक मैं नेक्स्ट क्वेश्चन करता हूँ, आप सोच के आंसर देना, बट डू नॉट यूज द इंटरनेट चैट जीपीटी एंड ऑल टू गिव द आंसर. आता है तो ठीक है, नहीं तो आई विल टेल यू. विच वन ऑफ द फॉलोइंग ड्रग डज नॉट प्रोड्यूस central anticholinergic syndrome? Very important question. It means the drug is not reaching to brain. The drug is not reaching to brain. So the drug which does not reach to brain. Atropine reach to brain. Yes, atropine reach to brain. That's what is causing confusion, delirium. Glycopyrrolate is one of the quaternary ammonium compound not reaching to brain. Antihistaminics can reach to brain, mainly first generation. Tricyclic antidepressants like amitriptyline, that is also reaching to brain and causing the central anticholinergic activity. So these are H1 antihistaminics which are causing. Tricyclic antidepressants are having anticholinergic activity, and atropine itself is anticholinergic. So out of these, glycopyrrolate is the drug which is not centrally acting, it is peripherally acting. It is the important drug for which type of patient? It is important drug for anti-secretory. It is used for anti-secretory, mainly used pre-anesthetic, before surgery, before anesthesia, to control the secretions. Glycopyrrolate is good because it is not reaching to brain, so do not interfere the CNS. Okay, now bache, the question ki sir, which is the specific binder for these muscle relaxants like rocuronium? So we have the Sugammadex. So Sugammadex is one of the binder which is available. Sugammadex is used as reversal for rocuronium. That's why rocuronium is commonly used. So glycopyrrolate is the good anti-secretory. Okay, mechanism of epinephrine in CPR. So why the first drug used during CPR is epinephrine? What is the mechanism? Decrease myocardial oxygen demand, increase S node activity, peripheral vasoconstriction and directly blood flow to heart, and increase subendocardial perfusion. So why we use epinephrine during cardiopulmonary resuscitation? Yes, bache, why we use? So what is the main reason? So during CPR, what we do? We push the heart. We are trying to revive the heart, but simultaneously we give the epinephrine. So what is the main advantage of epinephrine? It is do not decrease oxygen demand. No, it increase the oxygen demand. It increase the S node activity. No, it is having effect all over the heart, not on S node. It does not have any direct effect on S node. It is having the effect on all heart. Peripheral vasoconstriction and directing the blood flow to heart. Yes, that is the main reason. Basically, during CPR, our aim is to push the heart, but for that we need some blood in the heart. So from peripheral there is vasoconstriction, the blood is coming in the heart. During CPR our aim is to circulate this blood. So that's why this is the reason we use the epinephrine. Also it is having the effect on heart. It also having or pushing the heart or increasing the pumping effect of the heart. But that is the main reason. This is the reason we don't use norepinephrine. We prefer epinephrine, which is having the effect on the periphery as well as the heart. But this is the main reason. Also we can use one drug, vasopressin, for this purpose. Vasopressin can also be used for the same purpose. It do not increase the subendocardial perfusion. It is peripheral vasoconstriction which pulling the blood flow towards the heart. That is the first drug. Remember, epinephrine is the first drug during CPR. We use 1 is to 10,000. During CPR, we use the 1 is to 10,000 IV. 1 is to 10,000 solution. So 1 ml this adrenaline, 9 ml normal saline. 1 plus 9. So that will be 10 times dilute. Okay, out of the following structure, which does not respond to beta adrenergic stimulation, which does not respond to beta stimulation. It means where is the out of these structure where we do not have the beta receptor. Let's see. Ciliary muscle of the iris, which receptor is present? M3. That is for accommodation, ciliary muscles, M3 receptor. Radial dilator pupillae. In dilator pupillae, we have the mainly alpha receptor. Bronchial muscle, we have the beta receptor, beta 2 bronchial, and M3. SA node, we have beta 1. We have the beta 1. So basically, if you see out of these, we have the two option. That's why not exactly correct question. But instead of beta energetic, if I write the word sympathetic, then we get the correct answer. So sympathetic, then we get the correct answer. And then what will be the correct answer? Ciliary muscle of the iris. Ciliary muscle of the iris. So does not respond to sympathetic receptor stimulation. Then the option will be A, ciliary muscle of the iris. That is only and only acetylcholine effect. So remember, for circular fibers we have the cholinergic, and for radial fibers we have the dilator sympathetic. Next question, cholinomimetic drug useful for treating the post-op abdominal distension and gastric atony is abdominal distension, gastric atony. It means peristalsis is not there. So which cholinomimetic drug? M3 receptor stimulate. M3 receptor stimulate we use for intestine and bladder. So for bowel and bladder. So which drug out of these you will use for bowel and bladder? Out of these, which drug you will use for bowel and bladder, bachche? Which drug out of these will be used for bowel and bladder? Just a minute. Which drug you will use for bowel and bladder? B for bowel, B for bladder, M3 receptor is there. So what is the drug? Acetylcholine, bethanechol, methacholine, or neostigmine? What is the drug? Which drug you will use for this purpose? So remember, which is the selective drug for these areas? Acetylcholine is non-selective. Neostigmine is anticholinesterase, that is again non-selective drug. So which drug is there? Which drug is there? The drug which is selective for these areas, that is B for bethanechol. So remember, for bowel, B for bethanechol. So in M3 receptor, don't forget, in the bowel and bladder we have the bethanechol. So it increase the bowel and bladder. It increase the bowel and bladder contraction. So in the atony we can use the bethanechol. We can even use neostigmine, but that is not the best or preferred option. A known patient of bronchial asthma was started on treatment with anti-glaucoma drug. During the course of treatment, asthma worsened. Which drug is likely responsible for these symptoms? Now I have already discussed this topic, so every student should be aware of this. So is it timolol, brimonidine, latanoprost, or pilocarpine? So which out of these is risky in asthmatic patient, which is having the risk of bronchoconstriction? Is it timolol, brimonidine? Brimonidine is alpha 2, latanoprost is prostaglandin, pilocarpine is acetylcholine cholinergic, and timolol is a beta blocker. which can worsen, out of these which can worsen the asthma. So the main problem with anti-glaucoma is some drugs having risk in asthmatic patient, and that is beta blocker, because timolol is non-selective beta blocker. Which is cardioselective beta blocker? Betaxolol. The betaxolol eye drops, which is the cardioselective and can be used in these glaucoma patients. Chaliye. The next question, we have 3 more questions. A patient with history of snake bite present to emergency with symptoms of fatigue and irritability. 10 vials of antivenom already given, but the patient still having difficulty in swallowing, ptosis and respiratory distress. So muscle problem. What is the next line of management? So what you will do? In snake bite, first we give the anti-snake venom. Then what is the drug? If the muscle fatigue, difficulty in swallowing, ptosis, so which drug you will use? So definitely in these patients, neostigmine is a preferred option, because neostigmine is having the effect on NM receptor. NM receptor is present on muscles. But simultaneously atropine has to be given, which block the muscarinic effect of neostigmine, because in these patients we don't want muscarinic effect, we only want the nicotinic effect. So always give atropine with neostigmine to block these muscarinic effect in the snake bite, myasthenia gravis patients. Next question. A patient of 28 years of age comes to OPD with complaint of drooping of eyelid in the evening time. So drooping of eyelid in the evening. This patient is almost symptom free in the morning and muscle weakness increased during evening time. So after exertion, as a physician, you have noticed that the patient symptom worsen after giving one drug injection. Patient symptoms worsen after giving one drug injection. Diagnosis of myasthenia gravis was labeled by treating physician. So which drug was used to make this diagnosis? So which drug can worsen the symptoms in myasthenia gravis? There are 2 types of drugs which can improvement and which can worsen. For improvement, we use the NM stimulator, and if the drug is causing worsening, that means NM blocker. So which is for improvement? For improvement, neostigmine. For improvement, edrophonium. For IV immunoglobulin is basically for acute conditions. In acute crisis, we use the IV immunoglobulin. But which drug causing worsening? NM blocker. And which is the blocker out of these? The drug for blocking purpose is D-tubocurarine. Now many students will give the answer edrophonium, but that is wrong, because edrophonium is for improvement. Usually we use edrophonium, but in this question they are asking which drug will cause the worsening. The worsen will be caused by the curare NM blocker. Improvement with the edrophonium neostigmine. Edrophonium is preferred because short action and improvement is there. Chaliye, so now the second last question. Which of the following correctly describe the phenomenon of vasomotor reversal of Dale? So basically what we do in vasomotor reversal, adrenaline injection, adrenaline causing effect like this on the BP. Initially the BP rise because of the predominance of alpha, but in the low concentration, beta 2 action, beta 2 is sensitive, causing low BP. The adrenaline having effect on alpha and beta both. So you will see this biphasic response. Alpha causing vasoconstriction, but adrenaline metabolized, the level is low. In the low level of adrenaline in the plasma, only beta action, beta causing vasodilation. So if you give adrenaline with beta blocker, with alpha blocker, so what will be the effect? No alpha, only and only beta. So you will see the BP fall. And this is called as vasomotor reversal of tail. So adrenaline with alpha blocker. So patient pre-treated with phentolamine. Phentolamine is alpha blocker. Develop severe hypotension after adrenaline. That is the correct answer. That is the correct answer. This is called as vasomotor reversal of Dale. If I give beta blocker, then you can reverse the vasomotor reversal. So beta blockers can be used to reverse the vasomotor reversal. but adrenaline with alpha blocker like phentolamine or phenoxybenzamin, there will be no alpha action, only beta causing vasodilation. Always remember, alpha causing vasoconstriction, beta causing vasodilation. So A, B, C, D. Alpha causing C, beta causing D. C for constriction, D for dilation. That's why in pheochromocytoma patient where the epinephrine or catecholamine secreting tumor, in these patient first we give alpha blocker. If the patient goes to hypotension, we add beta blocker to reverse this vasomotor reversal. So alpha blocker followed by beta blocker. And this is the last question. One asthmatic patient, female, 22-week of pregnancy, having BP 158/100. What is the best drug to control her BP? Very tricky question. In pregnancy, what is the overall drug of choice? Overall drug of choice is labetalol. But labetalol is a third generation beta blocker, but that is a non-selective beta blocker. That is a non-selective beta blocker, and non-selective beta blockers are contraindicated in asthma. They are not safe in asthmatics. That's why the answer will be different. So we cannot use the beta blocker. So what is the best drug? So the best drug for these patients is, always remember, the calcium channel blockers are preferred. CCBs. Calcium channel blocker. So out of these, nifedipine is the calcium channel blocker. SR is the sustained release preparations. These are the long acting preparations. Simply if they ask, then the drug of choice is labetalol. But in asthmatic, we give the nifedipine calcium channel blockers. Otherwise, labetalol is the first choice. So this is all about the ANS question. We have discussed all the important question of ANS. If you have more doubt, then you can contact me at Instagram, Dr_Dinesh Yadav. So you can share your feedback, you can discuss the question, you can discuss any topic, or you can ask your doubt. Okay, so thank you guys. Bye bye. Take care. Good night. Please revise. In the next month, we will discuss the next topic. Before that, in our second year course, we have complete recording. You can watch those videos and then definitely you can practice the questions. Okay. Thank you. Bye bye. Take care. Good night.